So this time I'm going to talk to you about pre-op education and preparation. I cannot speak about patient education without talking about health literacy. So I have to define the concept of health literacy because they really go together. Describe ways to improve health literacy, explain the importance of pre-op education, and summarize the creation of process of patient education material, because there is a way that you can do patient education material, a process that will help. So I'm sure you all know this by now. If you don't, and then the end of the next 3 days, you will. So, and pre-admission counseling is right here. So, what is health literacy? Health literacy is the ability to read, understand, and act on health information. It's an emerging public health issue that affects all age, race, and income levels. It's the degree to which individuals can obtain, process, and understand basic health information and services they need to make appropriate health decisions. Research shows that most consumers need help understanding healthcare information. Regardless of reading level, patients prefer medical information that is easy to read and understand. For people who don't have strong reading skills, however, easy to read healthcare material is essential. Now, there's 4 characteristics that are linked with the concept of health literacy. There's the reading skills, comprehension skills, numeracy skills. Numeracy skills has to do a lot with how they understand to take their medication, how many times they're supposed to take their medication, and often that's why we have so many errors around medication. And their communication skills. How prevalent is low health literacy? In the US, 90 million people, nearly half of the adult population, have low health literacy. In Canada, 60% of our Canadians have low health literacy. This is a new survey, came out in 2012, and 8 European countries participated in it. Nearly 1 out of every 2 individuals had inadequate or problematic health literacy. This is a good article which I found written by these 2 authors. The authors found that nurses' knowledge of health literacy and their understanding on the role of health literacy plays on patient health outcomes was limited. Health literacy was also reported to be a low priority among providers and organizations. And I just think that it should be a high priority, because you'll see my next slide. Low or limited health literacy is associated with higher rate of hospitalizations, increased use of emergency and inpatient services, low uptake of preventative services, higher medical costs, and they're not compliant with their treatment, and medication errors. More, poorer health, increased risk of mortality amongst our seniors, adverse medical outcomes, ineffective management of chronic disease, and it's bound to have an economic impact on our healthcare. Reading level of patient education material was found to be at a grade 11.5. 1 out of 5 American adults reads at a 5th grade level or below. And the average American reads at the 8th or 9th grade level. Yet, most healthcare materials are written above the 10th grade level. Printed material should be accurate, easily accessible, and at the 6th to 10th grade reading level. 800 studies between 1970 and 2006 indicate most health materials exceed high school graduate reading levels. And that's what I mean by being able to write in plain language. I'm still struggling with it. It's very difficult to do. Research suggests that low literacy levels may increase with age, as people over 60 have difficulty reading and understanding the instructions for taking medication and instruction for future appointments. Did I do that? So there are factors that affect health literacy. There are the personal factors and there's the system factors. And under the system factors, we can motivate, we have an influence under it, but under the personal, we don't, like the literacy skills of our patient, the cognitive skills of our patient, the motivation they have to learn, the physical and emotional health, the experience with the healthcare, beliefs about their health, and the socioeconomic status that they have, and if they have any social support also. Under the system factor, which is us, we have the way we communicate to our patient, the provider's communication skills, the complexity of what we have to tell our patient, the characteristics of healthcare setting, where you are teaching your patient. Is there bells? Is there continuous distraction, people knocking on the door? And the time pressures upon healthcare professionals, that we all have time pressures, so we might be maybe talking a bit too fast. Can we predict low health literacy? No, it's not possible to predict low health literacy from just a person's behavior. However, there are certain behaviors that may point to low health literacy. They may fill in registrations form incompletely or inaccurately, and then they miss appointments. And you know after that what happens. They're labeled. They're not compliant. Well, she's not compliant. She's always late. Fail to follow through with lab tests, imaging tests, or referrals to consultants. Say they're taking their medication even though the lab tests aren't changing. They're unable to name their medication and explain what they are for, or even tell you when they're supposed to take them. And my favorite that I've seen so many times when I worked in the pre-op clinic for about 8 years was, I forgot my glasses at home. Can you help me? Now, of course, I'm not saying that everybody that forgets their glasses at home have low health literacy, but it should raise a red flag. So health literacy is not only about education, but it's about socio-cultural factors, and it's about us, the system, the healthcare system. What can we do to improve health literacy? We can test our patients' health literacy. Some scholars say that it should be the sixth vital sign. I am truly on the fence with that because I don't know. There are tools you can use that are very fast, but then what do? You certainly do not want to make your patients feel embarrassed. However, there is one simple screening question. It's called the single item literacy screener, and it avoids testing, and you simply ask, how often do you need to have someone help you when you read instructions or pamphlets or other written material from your doctor or your pharmacy? A 1, never, would be great. Anything higher than 1, probably at risk for low health literacy and likely needs assistance. So what can be done, again, to improve health literacy? I can't tell you about the screening or not because I've not decided. Create a shame-free environment. Use universal precaution, just like isolation, Use universal precaution so you address the same way, even if you know this person has a PhD or a high school diploma. Because remember, people like to have the same information no matter what. Basic. I've already mentioned the Ask Me 3 tool. I am going to talk more about the internet because our patients are surfing the net. Not all internet sites are created equal. And anybody who has worked with me know that I like images. So I think that adding meaningful images to patient education material, I always say it can make a difference between them throwing it in the garbage and actually reading it. So create a trustful environment to empower and encourage patients to ask questions. I think we need to slow down also, repeat and listen, less interruptions. There's a couple of studies that I read. Meanwhile, it was in a GP's office, but still, they calculated the time where patients were interrupted. And then on average, patients were interrupted by their physician between 12 and 16 seconds. So that doesn't convey, are you listening? Do you want to hear me? The teach back method, I'm talking about it very soon. Use plain language, avoid medical jargon, and no acronym. This, I think, might be happening often, and it doesn't need to be a physician. So the patient goes to see the nurse or the physician, and the healthcare provider talks, and the patients would say, okay, and yes, and any question? No. But instead of, he answered no due to probably intimidation, fear, lack of literacy, discomfort with the staff, or the inability to understand. But instead, if this healthcare provider would have used the teach back method, maybe the outcome would have been different. Maybe when the wife at home asked him what had happened, he would have said something else than, I don't know. So the teach back method, how do you use it in real words, in real clinical settings? So I wrote 2 examples you could use. Because it's always you put the responsibility on you. I want to be sure I explain everything clearly. Please tell me in your words what you heard me say. Or, my favorite, when you go home tonight, your wife, your husband might ask you what we have discussed. Just to make sure that I've explained clearly, can you tell me what you will tell them? And then you let them talk, and if they can't repeat anything, obviously they haven't learned anything. So you're back to explaining more. And, I preach that to the pre-op, and I don't think that pre-op really likes doing that because it's a change. But I repeat, we shouldn't ask any questions, or do you understand? No. The internet, it is growing. Nearly 75% of European households had access to the internet in 2011. In 2012, 83% of Canadian households had access to the internet at home, and in 2011, 75% of US households reported having a computer. That, I'm pretty sure, is outdated, but I couldn't find anything that was closer to today. 2/3 of internet users search for health information online, and it is now considered the 3rd most common internet activity. Patients will surf the internet, so refer your patients to reliable websites. I took a course this year on informatics, nursing and informatics, and I found this article, and I thought it was a good article. I'm sharing it with you for nurses, how to evaluate a website. So it's the 5 C's. I think nurses need to become skilled in reviewing their websites so that they can guide patients to the most appropriate sites. The 5 C's website evaluation tool provides a structured guide to such an evaluation, giving tips and suggestion key consideration. It was published in 2010 in the British Journal of Nursing by Roberts. Anyway, she has credibility, and under credibility, you have the authors. So you have to know who they are, and often what you see is about us. So you would have a tab written about us. They describe who they are. Currency, is there a date? Are there references to support their information? Are their links working or not? The content, well, is it accurate? Is it complete? The construction. Often a website for elderly, I'm talking about also, they would have an option to change the font size. So look for that. If there's too many distractions, like personally I don't like WebMD because on each side there's continuous advertisement rolling, and I think it can be very distracting for patients. And clarity, again, the level of the language. Anyway, I highly recommend before you suggest a website for your patients, go through the 5 C's to see if it's a good match, because there is a lot out there. So our clinical reality, we have our patients and we have changes to our healthcare delivery. Under our patients, we have aging population with chronic diseases, multilingual, multicultural. We need to synthesize complex information while our patients are in crisis and are stressed. We have fewer teaching moments and information as well as misinformation on the internet. Under the changes to healthcare delivery, we have fragmented health delivery models with a new definition of ready for discharge. They're shorter or no inpatient stays and same-day discharge post-surgery. So we all know that the length of stay is getting shorter and shorter. And again, the need to teach with less time and resources. How good is patients' memory? A review of studies examining patients' memory reports that 40 to 80% of the information provided by us is forgotten immediately, and half of what is remembered is actually recalled incorrectly. So this is why patient education material is important. It may help patients understand and recall the information, decrease anxiety, increase patient participation in care. Remember the Foley? He wouldn't have said anything about that catheter in his bladder if he wouldn't have that little booklet. Nurses' use of time more effectively. I think it provides consistent information, and it's meant to reinforce the verbal, but not to replace it. And it avoids surprises, patient not knowing their potential discharge date. So you go up and you go, well, you're going home today. Oh, I didn't know that. So I have to organize, and well, you have it in your booklet, and we went throughout with your booklet. Can pictures help in attention, comprehension, recall, and adherence? Well, according to Houts and his colleagues, yes, research in all 4 areas, including attention, comprehension, recall, and adherence, because that's what we really want, is the adherence part, showed that pictures can, in most instances, provide significant benefits. The effects of pictures on recall has been studied in education and psychology, and they call it the pictorial superiority effect. And that signifies that written or spoken text plus picture are better remembered than just text alone. The large number of studies reporting greater recall of text when accompanied by picture leads to the hypothesis that the addition of pictures to health education, written or spoken text, will increase recall for almost everyone and for almost all types of information, but especially for spoken information. And I had to put a little humor in here. When asked, how do you think? Einstein replied, once I understand, I see it in pictures. Let's pretend you're a patient, you're coming to the pre-op clinic, and I give you 5 of these. Ugh. I don't know, even me, when I get something in the mail and it's just like that, I don't have time to read it. It goes in the garbage often. But what if instead I give you this? What do we all do when we look at a magazine? We usually zoom in at the picture, and then we'll read under the picture. And if it's interesting, then we'll read the article. We have to make our patient education material interesting. By the way, this lady is having problems on the toilet because She's had surgery and she's taking pain medication, so she's constipated. A picture is worth 1,000 words. This is our pictogram. All of our care pathways have a pictogram. Actually, no care pathways gets launched until we have our pictograms ready and we have our patient education material ready. They are as important as medical orders. So we usually cover the length of the hospitalization. In our bowel surgery, we have 3 days. We target for 3 days. And we cover the breathing exercise, the activities, the pain control, the nutrition, and the tubes and lines. And in actual fact, I think we'll have to go back to the drawing board, because when I'm evaluating these, more and more people, I do not understand the floating toilet. These are printed in black and white, and it's great now because you can see the Foley in yellow. But when we can't afford color, so we print in black and white, and people are not understanding. So we'll have to figure out something else. We will. So what are the benefits of using patient education material? Improve health knowledge and recall, promotes learning and increased knowledge, promotes decision-making and self-management, provides consistent information, increases patient satisfaction, use of time more effectively. This is a process that I suggest when you're going to start doing your patient education material. Step 1 is to identify your purpose and patient population. Don't reinvent the wheel. Check for existing resources. I'll be glad to pass them on. Not that you want to use mine, but if you want to have a model. Establish an interprofessional team. I can't tell you how often that I think it's the final draft, and I send it to my team members, and they all have something to say. Plan timeline and budget. Conduct a needs assessment. Develop your content. Again, write in plain language. Apply clear design and layout. Translate into whatever second language you have in your country. Evaluate your patient education material. Obtain appropriate approvals and produce, distribute, and use. Here it says to reevaluate after 5 years. I'm really always reevaluating it. As soon as we change something in our medical orders, well, I have to go back and change it. It's going to reflect the pathway in the patient's booklet. So it's an ongoing process. So things to consider: what are the learning needs of your specific audience? Are the learning objectives appropriately defined? Is there any way to measure whether you have met them? Have you integrated issues such as literacy, health literacy, plain language standards, as well as those created by your institution? Are you including unnecessary distractors? Keep in mind, you might want to add images, but if the images are not meaningful, don't know. Are you addressing cognitive load? Are you increasing it? So decrease it by focus on the need to know information only. Do the images work for or against you? Is the design easy for the learner, patient, family? And that could be also a website. Doesn't have to be. It could be on the internet. Doesn't have to be paper. Is the material easy to navigate? And is your message consistent? So why create a patient version of the care pathway? To increase patient participation, to increase understanding of care, to encourage your patient to speak up, to have new and updated patient education material. It is always on the nurse's responsibility to do the patient education material. It is often not a priority. Please make it a priority to increase consistency. I'll finish off my presentation by saying that even though we live in an industrialized nation, our literacy level is low and will not increase in the next 20 years. There are things we can do, tools and strategies that we can take to help patients understand better and get involved into their care. Low health literacy is common. Increasing the health literacy level remains at the foundation of patient involvement. We know there are several benefits for surgical patients to receive pre-op teaching. However, not many studies look at when is the optimum timing to do this and what is the best method of delivery. Future directions and research should focus on creating and testing interventions on ways to improve communication and health outcomes. Creating patient education material is a critical component and an important step in the creation of an enhanced recovery care pathway. Thank you.